So, okay, we're recording. So for those who are new and haven't logged in before, I'm Rhea Markowitz. I'm in the Georgia Cancer Center, and I'm part of the hub team of teledermatology in rural Georgia. And Dr. Doug Patton and I will be serving as co-facilitators of this session. So if you can, we'd like everyone to have their cameras on so we can see each other, especially when we are having discussions. So I ask that of you. So the big news here at TeleDerm in Augusta is that our team member, Kenza Mamouni, who's usually here on the computers, had her baby daughter, Kalilia, about 2 weeks ago. So she is off on maternity leave for a while. You'll see that the group here looks a little different from what we usually look like. Brenda Santiano may be logging in, although I haven't seen her name, but she is visiting her parents right now and is with family, so she's not here. So in their place, we have new team members, Mu Sharara and Mohammed Siam, and they are handling the controls. This is their first time that they're in charge, so we may be a little bit slow, but we've been practicing, and hopefully things will go pretty smoothly. So let's see, other welcomes. We want to welcome all of our TeleDerm clinic healthcare providers. I'll list the clinics, and if you folks are on, put your cameras on and give a little wave. So we have from the East Georgia Healthcare Centers, we have Mount Vernon, we have Soperton, Evans Health and Wellness, Baxley, Metter, Sylvania, Wadley, and I'm not sure if Swainsboro is on today, but they are a new clinic that are joining us, and so we'll be attending. We also have from the Albany Area Primary Healthcare Group, we have Lee Medical Arts. I'm not sure if Dawson and Edison are represented. And we've added Phoebe Family Medicine Residency Program. Not sure if they are here today, but will be joining us soon. And of course, want to welcome our TeleDerm, our dermatologist, Dr. Davis, who might not be here yet. I know she had a conflict, but she'll be coming late. Dr. Rabinovitz, and of course, Dr. Buchanan. I've introduced our hub team members. Remember to put into the chat your name, your email address, and your clinic affiliation or resident or whatever. And there should be samples in the chat already. So if we can go to today's agenda, no, earlier slide, should be slide 2. There we go. So we start as usual with the introductions that we've just done. Dr. Davis Diamond will be doing the didactic session, followed by questions, and then we'll have a case presentation by Nicole Micklus, a 4th-year medical student here at the Medical College. And we'll have discussion, and then we'll have a wrap up and announcements. So I think now is the time that I introduce you to Dr. Doug Patton, who will take over. Dr. Patton is the Dean of the Southwest Georgia Medical College of Georgia Regional Campus, and has spent most of his career as a rural physician. So, Doug, take it away.
Thank you, Rhea. It's good to be here today. It's good to be with some familiar faces and some new ones as well. We want to welcome the new team members just like Rhea did. And thank you all for jumping in. We'll go through these quickly, but these are just reminders that the TeleECHO, TeleDerm sessions are meant to improve knowledge through telemedicine and teleeducation. Our goal is to address dermatologic health disparities faced by people principally living in rural areas of the state where access to dermatologic expertise might be limited. Next slide, please. So this is for educational quality improvement purposes only. And because of that, these sessions are all recorded. And by participating, you're consenting to be recorded. As a reminder, these are not teleconsultations, so we need to be mindful not to mention any PHI during the discussions or to show any images that would reveal PHI. There will be information towards the end about CME and CNE. Those will also appear in the chat as well. If you have questions, you can always email us at teledermatology@augusta.edu. Next slide, please. So we do collect data beginning with registration and all the way through any surveys, post-event surveys. This includes the recording, of course, but also the information you provide in the chat so we can keep track of who's participating and use all of this information for the purposes of improving the product that we deliver. Next slide, please. So general, keep your microphone muted when you're not speaking. Unmute yourself when you do. You can type questions into the chat, or you can raise your electronic hand, which you get by hovering over your reactions button on the bottom of the Zoom screen and picking the raise your hand option. Please leave your cameras on as much as possible. We do realize that some of you are in limited bandwidth areas and might not be able to have your cameras on all the time, but please, as much as possible, have those on so we can have full visual as well as audio engagement with the group. Gallery view allows you to see as many people as possible. Sometimes for the purposes of presentation, it may be important for you to use the speaker view so you can see the screen. Use your discretion. We're all getting good at this. Technical problems, you can email Moo, one of our new teammates, at moosharara@augusta.edu. Next slide, please. All right, it's time now for our didactic presentation. We're going to welcome back Dr. Davis Diamond, who is a chief, or at least a senior level resident. I don't know how that works in your program, but he's a senior level dermatology resident at the Medical College of Georgia. And he's going to present to us today on skin cancers in skins of color. So an area that is very important to all of us who practice in rural environments around Georgia, as we tend to have a very diverse patient population, many of whom have darker skin tones. It will be important for us to put our questions in the chat, and certainly we'll have a few minutes, hopefully at the end of Dr. Diamond's presentation, for us to address some of those questions either through the chat or through raising your hand and asking him directly. So at this time, Dr. Diamond, welcome back. I'm going to ask that you share your screen and you take over from here. Thank you.
Thank you. You guys hear? I'm assuming you guys can hear me okay, and that my slides are what's up right now.
We can see your slides and we can hear you terrifically.
Perfect.
Thank you.
All right. So yeah, I'm Davis, fourth year resident here, entering my last kind of 6 to 8 months. Today, talk to you guys a little bit about skin cancer and skin of color, which is a topic that even at a dermatologic residency level is not extremely well taught, and something that there's been a lot of emphasis at a national level for dermatology to really get a better understanding of all this. So, all right, so just skin cancer in general. Skin cancer is the most common malignancy in the United States, and the vast majority of those skin cancers are going to arise in Caucasian patients. Skin cancer comprises anywhere from 2 to 4% in Asians, and then 1 to 2% of neoplasms in Black patients, and also Indian patients. So even though we see skin cancer at a much lower rate than we see it in Caucasian patients, when we do have skin cancer in patients with skin of color, there's increased morbidity and mortality. And, why is that? Well, first of all, patients with skin of color are much less likely to go to a dermatologist in the first place, or maybe be referred to a dermatologist, or maybe there's just inherent, healthcare discrepancies in, their, general kind of screening overall. And then when they get to the right person, does that person even know, what to look for in these patients? So, like I said, there's a huge push right now for education and getting people to not only recognize, these skin cancers in these patients, but then, treat them appropriately. So I'm kind of going to just do this. I'm going to show a lot of pictures and go over the three most common types of skin cancer we see, and then I'll touch on a couple rare ones. But we'll start with basal cell carcinoma, which, for us in clinic, that's the most common neoplasm we're going to see. It is the most common type of skin cancer in Asian patients and Hispanic patients, and then the second most common type of skin cancer in our Black patients, and then Indian patients. And if we think about it, as a patient is more darkly pigmented, we use a scale called Fitzpatrick scale, but I won't get into that. But anyways, as a patient has darker skin, they're less likely to get a basal cell carcinoma. So an Asian patient, which is, their pigment is more similar to a Caucasian patient, they're a little bit more likely to get a basal cell compared to a Black patient who's more protected just by, they have inherent photoprotection from, melanin. And so these kind of from chronic UV radiation, these will arise later in life in the, fifth, sixth, seventh, eighth decade and so on. And, everybody talks, even in skin of color, it's going to be these pearly papules, or, these eroded plaques with rolled borders and telangiectasias and erosions. And I know we've gone over dermoscopic features of these probably ad nauseum in these sessions. So I'm just going to talk kind of more about, gross morphology. And then in these patients, something that's interesting is they're more likely to exhibit pigmented basal cell carcinomas. About 50% of the time when they have a basal cell, it will be pigmented. I think in Caucasian patients, it's more like 5 to 10% of the time. So one big difference there. And, here we can see, on the right-hand side is just an eroded plaque with these rolled borders and maybe some increased pigment at the periphery. Here is a Black patient that has an eroded plaque, probably pretty indurated to the touch, but this is obviously something that needs a biopsy or needs to be referred to somebody who can biopsy it to further characterize it. I don't think it'd be hard to make a confident call on a spot like this without a biopsy, because there's been so much secondary change and all that. And then, even when a patient identifies as Black, or, what we would consider skin of color, you have to consider, with the basal cell, the reason why patients with skin of color don't get it, it's not because of their inherent genetics, it's because of their melanin production. So if they have some sort of inborn error of melanin production, like this patient here has oculocutaneous albinism, and you can see that very, lightly pigmented hair above his ear there. They're at a very high risk for getting basal cells and squamous cells and things like that. So take that into consideration. Just because the patient identifies as a certain, ethnicity doesn't mean that, their skin cancers are going to play by the rules by what they, where they say they come from. It's more about the melanin production itself. So, and there's other, genetic conditions, but we're not going to get into the weeds with that. I think albinism would probably be the most common one you might see. And then here is just, this is a pigmented basal cell on the nose. Assume this probably has been there for a really long time. So, and for this patient, this is going to be an extensive surgery to get this off, with probably a 2-stage repair and Mohs. So you really want to get these patients in as soon as possible if you're, worried about anything like that. So squamous cell carcinoma. Squamous cell carcinoma in white patients is the second most common type of skin cancer. It is more dangerous than basal cell carcinoma, so we do worry about it a little bit more. It is going to be the most common type of skin cancer in our Black patients and Indian patients, and then the second most common type of skin cancer in Asian patients as well as Hispanic patients. So it's different from how it presents in white patients, especially with our Black patients. They more often get squamous.
We lost your voice.
Is it back on?
Yep.
All right. I don't know where I cut off, but I was saying squamous cell skin cancer in white patients is generally on sun exposed skin of the head and neck or the trunk, but in black patients we see it more often in sun protected areas. So it's less of a UV radiation driven tumor compared to the ones that we see in white patients. So why are they getting squamous cell carcinomas? Well, squamous cell carcinoma is also, so it's well known that it's associated with chronic inflammation or scarring processes, and those kind of diseases that we see in skin of color are things like discoid lupus, hidradenitis, or just thermal burns or chronic ulcers for from whatever reason. And then typically what we see with the squamous cell carcinoma are these hyperkeratotic papules or plaques with or without erosion. And similar to basal cells, how they present more often it's going to color with pigmented variants. You're more likely to see a pigmented squamous cell carcinoma in skin of color, which is honestly not something we see very often in white patients. So, and then here's a classic squamous cell carcinoma on the lower lip here with a good amount of erosion in the middle there. So this is more of a classic picture. You have a hyperkeratotic papule here. It looks like it's on the arm. That's something that definitely deserves a biopsy. And just talk to your patient about the chronicity of these spots. If they've been there for a couple months, it needs referral. Ask them if they've been picking at it, things like that, if it's painful. And then I was touching on, sometimes we have these patients with these chronic inflammatory processes. Well, discoid lupus is a fairly common, inflammatory condition, autoimmune connective tissue disease in Black patients. And we see it quite often at MCG. And we've actually had a case where this happened. And so on the left here, what we're seeing is just kind of a scarred patch. And that's not cancer, that's just discoid lupus. Now, these patients should already be followed by a dermatologist at this point. But, if they're not seeing a dermatologist, you need to pay attention to these areas, because anytime they start developing, a new nodule in it, it's very high risk for a squamous cell skin cancer. And these squamous cell skin cancers that arise in areas of previous scars or ulcers, they're bad actors. They generally are extremely aggressive, and their tendency to metastasize is higher than a normal squamous cell. So these are things that we need to catch very early. We had a woman that had something like this, and she lost her entire lower lip and her face, and she needed a neck dissection. So, the sooner we can get these patients to the dermatologist or get them in for the proper evaluation, the better. Here's an example of a patient with a thermal burn on his left leg that you can see kind of at the periphery there. It looks like, it's an indurated plaque. And this is a squamous cell. Also, this is a very large squamous cell. But, like I said, consider burns any area of trauma, chronic trauma. And then here's a patient with hidradenitis, which is another, very common inflammatory skin disease in patients with skin of color. And squamous cell carcinoma can develop in these areas. This is actually perianal. I don't know if the defect ended up looking like this, but you can assume how much this would affect your patient and their quality of life. So you want to catch these things as soon as possible or get them over to the right people. And then one final consideration, and this isn't necessarily more often occurs in skin of color, but I've seen these a couple of times in patients with skin of color who kind of get a new papule in the inguinal area or perianal area, anywhere really in the kind of groin, and they look a little bit more warty, or what we would say in dermatology is verrucous. You have to consider that squamous cell carcinomas can also be driven by HPV infection. So if you have a patient that has a complaint that they have a new spot down in their groin or that area, you need to make sure you evaluate it and refer for biopsy if necessary. So then the thing that everybody worries about the most is melanoma. And similar to Caucasian patients, melanoma is the third most common cutaneous malignancy in really all ethnicities of skin of color. And something interesting that I was reading while putting this together is, while we are seeing an increased incidence of melanoma in our Caucasian patients, the incidence has remained stable in skin of color. And like the squamous cell carcinomas that I was talking about before, especially in our patients with the most pigmentation, these generally are not UV radiation driven tumors. So in Caucasian patients, we often see melanomas on the back or the legs, places that get a lot of sun intermittently. But in Black patients, we most often see it on the palms, the soles, or on mucosal sites, meaning that it's obviously not UV driven. It's coming from other genetic causes. The type of melanoma that we most often see in skin of color is acrolentiginous melanoma, which I have a picture of that on the right here. And acrolentiginous melanoma is most often on the sole where we're looking here. Like I was saying with squamous cell carcinomas, there's increased morbidity and mortality in skin of color with skin cancer, and melanoma falls into that bucket as well. And there's actually a pretty big gap between the 5-year survival in Black patients compared to white patients, and any studies showing it over and over and over again. And whether that is because these are being found at a later stage, or patients aren't even getting evaluated, in a timely manner, there's a lot of different reasons for it. But you need to know what it looks like. It can be really tricky on the palms and the soles, and you need to get a good history from your patient talking about chronicity. And if they're worried about it and they think it's new, it's probably a lot of times the right thing to do is biopsy it. So here's another acrolentiginous melanoma. Things you want to look for in this is a poorly circumscribed lesion that's been evolving over time. There's multiple colors, and then there's characteristic dermatoscopic features with similar to any other melanoma. Something that can be really tricky is that in skin of color, there's a higher incidence of melanoma in the nail unit, and sometimes especially in Black patients, there's something called just physiologic melanonychia, which means they just have pigmented bands in their fingernails that are completely benign. So you really got to get a good history from these patients. This patient on their second digit there has a hyperpigmented streak longitudinally going up the nail. And if they tell you that they've had this since they were a kid, this is completely benign. It doesn't need a biopsy, nothing to worry about. If you see these on multiple fingers, it's a little bit more reassuring than if you just see a new one, or if you see a solitary lesion or one that has arisen later in life, anywhere kind of after adolescence. Whereas this one right here, we're looking at, this is a melanoma. And so the melanocytes where the melanoma begins, they live in the matrix, which is under the proximal nail fold or the cuticle. And so, one of the signs we look for when we're evaluating melanoma of the nail unit is we see if that pigment kind of spreads onto the skin, and we call that the Hutchinson sign. But anyways, here you can obviously see that there's pigment on that proximal nail fold kind of near the cuticle, and then you have distal nail dystrophy with that as well. These need to be referred to not only a dermatologist, but a dermatologist who does nail biopsies. Not every dermatologist does nail biopsies. We do them here at MCG, but just make sure you're communicating when you send these patients out, because these need to be taken care of pretty quickly. These are fairly aggressive. I have a picture of what that looks like. Sorry if you guys can hear my dogs. I know I wouldn't make it 20 minutes at home without them going crazy. So this is how a nail matrix biopsy is performed. Like I said, the matrix is under the cuticle there, so you have to reflect that proximal nail fold back in order to get a good representative sample to send to your pathologist. So make sure you're sending it to somebody who actually does this procedure, because like I said, these should be sampled in a fairly timely fashion. And then here's just a nodular melanoma on the trunk. This is what everybody classically sees when they think about melanoma. These should be caught in clinic and referred. If you see something like this needs to be sampled yesterday. So make sure you get them in quickly. And finally, I'm just going to kind of do a case-based one here. So, a lot of skin of color, they're more likely to develop keloids, and that's what these are right here. But patients oftentimes get their keloids excised and they recur at the site, and the patient will mention it to you, and sometimes you don't think twice about it. But I just want to show this case because there's a rare skin cancer that looks a lot like keloids, and we often hear this story where a patient has had a keloid cut off, and then they have a keloid recur at the same site, but it's a little bit different. And so, let's say they had one of these keloids excised, and then they come back and it looks like this. It's outside of where the margins were before. You put your hand on it, it feels like it's kind of deeper and more fixed. That makes you want to worry about a different type of skin cancer that most people aren't, very well aware of, but something that we definitely see in clinic, and something that can be disfiguring and can be tough for these patients to deal with. So this is called a dermatofibrosarcoma protuberans, or DFSP, if you want to shorten that really long name. we often see these on the trunk or the neck of 20 to 50-year-old patients, so a little younger than the population we see with other types of skin cancers. These are locally aggressive and can be destructive in the area that they grow in, but they rarely metastasize. And these should be in the differential if you're looking at a keloid and it doesn't look right, it doesn't feel right, it feels a little bit deeper than you would expect. And make sure you get these sampled so we can get these treated the right way. These are more common in Black patients than they are in white patients and other ethnicities. And treatment for this, similar to other skin cancers, you can send them for Mohs, you can send them for excision, or if you can't get clear margins, you can even use oral chemotherapy. So that is all that I have. Thank you.
Thank you, Dr. Diamond. That's terrific. We already have one question in the chat, and it comes from Kyle Kennedy, who's with East Georgia Health System. It's coming from the Swainsboro office, which, if I understood correctly, is a new site for us. So welcome, Kyle. And I'd like to give you the opportunity to ask Dr. Diamond your question yourself.
No,
Go ahead.
Yeah, go ahead.
So I was just going to ask you, these people that we see with these chronic inflammatory conditions, is the right call to just say, hey, I think you need to have an annual visit with a dermatologist just to do a full skin inspection, just because y'all are the experts, versus us waiting around for something that, is like obvious, needs to be evaluated with dermatology? Is that a good idea?
I think, ideally, in an ideal world, you get all these patients out to a dermatologist and have them evaluated. But I know what the reality is. And for some of these patients, that's really difficult, or there's just not access. Even though there's an increased risk, most of these patients are never going to get a squamous cell carcinoma in their discoid lupus or an area that they have hidradenitis. But I would say be aware that it's a possibility. And if you have any concern or something is growing in an area that that they've had disease in before and it doesn't look right, have a very low threshold for referring them, or with a program like this, sending a picture over to dermatology so they can at least take a look. But no, I don't think every patient with hidradenitis needs a yearly skin exam for to evaluate for skin cancer. It's an associated risk, but it's not so high that necessarily everybody needs it.
That's
Thank
terrific. Thanks, Kyle, for the question, and thank you, Dr. Diamond, for that response. I think, Dr. Diamond, you hit on something perfect there, because one of the aims and goals of this program is to enable people to use a teledermatology solution to be able to take a picture of something that looks suspicious or worrisome and be able to pass it along to get an expert opinion. And that's exactly what we hope would make it easier for people who are in these remote settings. Kyle, to your point, I think a lot of what we see in the rural areas tends to be agricultural related. So there is sun exposure, there are burns, there are chemical injuries and things like that might escape the view of someone. So when they do come to a primary care setting, it's important that we ask about those things and take a look. I see that Lynn Allman has a question. So Lynn, would you like to ask that question?
Yeah, hey everybody. I actually had a patient come in today who's got massive keloids, multiple of them. And I don't know that there's anything unusual about them, but so this may not be the right question. But is it appropriate for me to scan a couple of those, send them off? And then the next part of my question is, if she needed treatment, is derm where she would go for that, or plastics, or what?
So when you say scan, do you mean take a picture or
Yeah. Sorry.
Yeah, always easy to take a picture and have us look at it, because we see this is what we see all day. But in terms of treatment, yes, dermatology does take care of these. If you send them to a place like MCG, that's a large integrated health system, we have them come back several times. We inject them with Kenalog. We get them soft enough to excise them. And then we actually coordinate with radiation oncology. They radiate the base to, give us the best chance of these things not recurring. So you want to, I would say, just send it to somebody that deals with these on a frequent basis. Because if you just send it to somebody who's just going to cut it off without doing any preoperative Kenalog injections or postoperative radiation, the patients are going to end up worse off than if you never touched them in the first place.
Right. So my next part of that is, and I don't know the answer to this, and I'm retired from MCG, so I know the system. I'm not sure that she's got the best insurance. And then my question is, if I send a referral, how long is it going to take for her to get like an appointment? That's why I didn't know if this program would be helpful in doing that, or, you know.
So if I can interrupt, so Lynn is you're at EGHC Wadley, right?
Correct.
So that's one of our participating clinics. So you have the most scope, but Lynn is new to that clinic. So you have the most scope, and you can examine it with the most scope and send the referral, and with the Derm Engine, and Dr. Buchanan will get it and will give an assessment and so forth.
Okay. I'll just take some pictures and send it on and send the referral then.
Okay, great.
Thank you.
That's terrific, Lynn.
Yeah, and
Thank you.
usually these are more of a clinical diagnosis. You know, I don't necessarily use dermoscopy routinely for keloids. I mean, sometimes I do, you know, just to look for certain features that can be seen in scars, but typically this is a clinical diagnosis. But once you send the referral to me, I will give you that feedback, but I don't actually schedule any additional follow-up for the patient on my end.
No, I understand that. Yeah, I mean, it's literally like 12, 14 centimeters, and that's the big one. And she's got multiple of them, and they've been there, and they're itching and they're hurting. And so that's why I'm looking not only at just this program, but then after this. So.
Yeah, Lynn, if you send me an email, I'll be happy to give you the contact of who you can send the referral to.
Okay. Thank you.
So this is perfect Project Echo TeleDerm in action. I am so thrilled.
That's terrific. And Lynn, we appreciate the question. We welcome you to the program. And I see also, I guess you're at the Wadley Clinic, and I'm going to have to do some geography and figure out where the Wadley Clinic is. So, but thanks for joining us and asking that question. Other questions right now? We have time maybe for one more before we move on to our next case. I can't see all the participants. Let's see if I go to gallery, make sure I'm not missing a hand somewhere. Looks like I don't see anything else at this point. It doesn't mean we're done. We can certainly have other questions from this to come later. So if you think of something later, you can put it in the chat, or you can just put a chat in there or raise your hand when we get back to questions. But in the meantime, we're going to move on to our next case presentation. So we're fortunate at this point to have our case presentation delivered by Nicole Micklus, who is a fourth-year medical student. Nicole, I'm going to ask if you're ready to go ahead and share your screen, and then you can take over from here and do your case presentation. So.
Awesome. Thank you so much. Let me figure out share screen. Okay.
There you go.
It loads. Are you able to see my slides?
I can see the slides. They're in presentation mode, but that's okay. Why don't you just go ahead and we can. There it is. That's perfect.
Perfect. Okay, well, thank you, everyone. My name is Nicole Micklus. I'm a fourth-year medical student at the Medical College of Georgia, and I am going to be giving you all the 18th case presentation. I quickly want to say thank you to Dr. Buchanan for helping me put the presentation together, and as well as Lori Hutchins for giving us this case today. So we can go ahead and get started. So this is an 86-year-old male who's had an itchy lesion on his left cheek for 1 year. It's been stable in size. He is Fitzpatrick skin type 4, meaning he's of Hispanic Latino ethnicity, and he has no previous history of skin cancer. So here is the lesion we were referring to. It's a little blurry, but clinically this is a blue to brown papule with a little focal erythema and a small bit of ulceration. Also, this is a teledermatology consult sent to Dr. Buchanan through the Derm Engine platform, and it's the first case that we are presenting from this platform, which is pretty exciting. So our clinical differential includes a pigmented basal cell and a melanoma. At this point, I want to mention that facial melanomas are not typically nodular. They're usually more isolated, flat pigmented lesions on associated chronic sun damaged skin, but it's not impossible to see a nodular melanoma on the face. Additionally, this could be a traumatized angioma, an irritated intradermal nevus, an inflamed seborrheic keratosis, and then if you really squint, maybe a blue nevus. We have a little bit of blue pigment in there. So we're going to go ahead and take a closer look at this. So this lesion we're going to evaluate with pattern analysis. So overall, the symmetry of the lesion, its shape is symmetric, but it's asymmetric in pattern. So we see multiple colors: blue, brown, white, red, yellow. So overall, we can pretty much say that this is a disorganized, chaotic lesion. Sorry, my mouse is getting ahead of me. So I'm going to use this revised two-step algorithm instead of the typical melanocytic versus non-melanocytic, just because of the lesion we have. So overall, we've already determined that it is not very organized lesion. It does not have homogeneous skin pigment. It is not uniform in color. It doesn't have a nice pattern of vasculature. So overall, we can say that it does not fall into one of these categories. So moving on to our step 2 of the algorithm, malignancy should be considered in a lesion that is disorganized. So we're going to take a closer look at the basal cell carcinoma section. So as you can see, the first feature we note is the blue-gray ovoid nests in the periphery, as well as these shiny white structures, which are best viewed under non-polarized light. With polarized light, sorry about that. And then we also see this ulceration or yellow color. I also want to note that underneath that ulceration, there's this atypical vessel. It doesn't look like our classic arborizing vessels that we're used to seeing in the pearly pink papules of a classic basal cell. They could be shortened vessels, they could be twisted loop vessels. It's really non-specific, but there is an atypical vessel in there. So given these characteristics, we want to go ahead and biopsy this lesion to rule out a basal cell carcinoma. So that is exactly what we did. And at follow-up, the biopsy was performed by a local dermatologist, and the diagnosis was a pigmented ulcerated nodular basal cell carcinoma. Incidentally, there was also a nodular basal cell carcinoma that was biopsied from the right cheek at the same time. And here's an example of the pathology in the bottom right-hand corner where you can see the basaloid tumor islands. The lesion was removed and treated by the outside dermatologist. So I want to say a few things about pigmented basal cell carcinomas. They are a subtype of basal cell carcinomas, and they're very common in skin of color, as Dr. Diamond was saying in his presentation. As far as the lesion goes, it doesn't have to entirely be pigmented. Most of the lesions, there was less than 50% pigmented noted. As well as in Hispanic populations, the pigment was twice as frequent in basal cell carcinomas of patients with Hispanic surnames than individuals with non-Hispanic surnames. So pigmented basal cells are pretty much twice more common. So more key points of basal cells in Hispanic patients. This table that I screenshotted is a review study that highlights dermoscopic characteristics commonly seen in the Hispanic population. I want to note here the reference to these shortened vessels. There we go. These shortened vessels, which was a main dermoscopic feature in basal cells in Hispanic patients. So not the classic arborizing vessels that we're used to seeing. Additionally, Hispanic patients are more commonly going to have a basal cell carcinoma on the right side of the body compared to the left. One study hypothesized that this was due to environmental UV exposure, which makes complete sense, but they were unable to determine what exactly that exposure was. Hispanic patients are more commonly Hispanic men more commonly underwent Mohs micrographic surgery for non-melanoma skin cancer versus women. And this is possibly due to the due to the distribution of the workforce. So Hispanic males are more likely to be working outdoors in construction and agriculture and less likely to be applying sunscreen. So one study found that 69% of Hispanic outdoor workers rarely or never applied sunscreen. So not only is it important that we're screening these patients for skin cancer, but also counseling them on appropriate use of sunscreen, especially if they're working outdoors. Additionally, a higher percentage of Hispanic patients had non-melanoma skin cancers in high-risk locations. So that included the eyelids, the central face, the ears, the lips, the nose, the genitalia, and the hands and feet. So this is just a quick review of some of the features of basal cell carcinoma. First, we have the arborizing vessels. These are spoke wheel areas, leaf-like areas, which are also very common in Hispanic patients with basal cell carcinomas. Multiple aggregated yellow-white globules, blue ovoid nests, which would indicate like a nodular component to the basal cell carcinoma, blue-gray dots, shiny white structures best viewed under polarized light, and then ulceration. So in summary, why did I pick this case? To highlight features of skin cancer and skin of color, to highlight dermoscopic features of a pigmented basal cell carcinoma, and to highlight a case from our teledermoscopy consult platform. And so questions for the ECHO team: how can we distinguish a pigmented basal cell carcinoma from a melanoma?
Thank you, Nicole. That's great. Anybody on the ECHO team want to take a shot at giving us a concise answer to that?
I can take a stab at it. So I like this case. It was challenging because we are using the mole scope, and it does highlight certain features that we can see with polarized dermoscopy. It doesn't have the feature of non-polarized light. So for me, usually when I see this sort of blue color with that ulceration, pigmented basal cell sort of gets to the top of my differential. I do think you always have to think about a nodular melanoma. They tend to have different patterns than those that we've talked about before, those that we typically see on chronic sun-damaged skin. So nodular melanomas can present with that blue-white veil that we've talked about before. You can often see shiny white structures. Usually they're in the form of strands that can be parallel or orthogonal. And then overall nodular melanomas can also be pigmented or non-pigmented. So they can be amelanotic and be red with polymorphous vessels, or you can have nodular melanomas that are primarily black or blue that tend to be very symmetric and organized. So it should definitely be on your differential. There's other features that I won't go into detail about, but for the most part, whenever you see multiple features in this patient that are supportive of basal cell carcinoma, that's usually first on my differential.
Thank you, Dr. Buchanan. That's terrific. I'm scanning. I don't see any other hands raised or anything. I may call on our friends down at Phoebe Family Medicine Residency and just first of all, welcome you to the program. Glad y'all are here. I saw several of you signing in. And maybe there's been some conversation inside the room, Family Medicine Residency. Anybody there have a question? Don't be shy.
I don't have a question, but just a comment for the first case with the D dermatofibroma, the SP. I just saw a case of it on my surgical oncology rotation. The surgeon had removed he removed it, but actually from the scalp. He said that was very rare for him to see it on the scalp as well. So I thought that was just nice that I got to see another play of it here.
That's terrific. Thanks for that share, Dr. Wilson, and welcome.
Thank you.
So Nicole, I'm going to put you on the spot again. Thank you for sharing that case. But tell us, just give us like a 15, 20 seconds on the Fitzpatrick scale and help us kind of understand about prevalence of cancer in lighter skin versus severity in darker skin. Not hard.
Dr. Diamond kind of alluded to it in his presentation, but so Fitzpatrick 1 being very, very fair skin, blonde hair, blue eyes, and then it just kind of goes up from there. And Fitzpatrick, I think 5 or 6 is the like darkest skin type that you can get. So Fitzpatrick 4 is our Hispanic Latino population, a little darker skin types and a little darker hair, but not quite the pigment we would see in our African American patients. And like Dr. Diamond was saying, skin cancer is way more prevalent in our lighter Fitzpatrick types, but it's not uncommon in darker skin pigments. And we're more commonly going to see these pigmented basal cell carcinomas and pigmented squamous cell carcinomas.
That's terrific. Dr. Diamond, I think you, in your experience, would probably agree that when we do see them in the darker skin population, they tend to be at a more advanced stage by the time we find them. Let's see. You're muted.
Yeah. I think it's for a couple of different reasons, or at least I hypothesize it for a couple of different reasons. I think one, I don't think these people are getting to the doctor fast enough. And I don't think doctors, dermatologists, we don't see this a lot. It's not in our textbooks. It's not online. And I had a hard time finding pictures for this presentation. And I mean, this is only, 20 slide presentation. So it's just not something we don't have enough reps with it. And then also, because these aren't UV driven tumors, I think they often have different genetic profiles that lead them down a more aggressive route, and they're more they become their malignancy, their kind of their potential to metastasize or be more locally destructive. I think because they have this different kind of genome that it's working with, or mutation kind of profile it's working with, I think that contributes to the poor prognosis for these patients.
It's great insight, Dr. Diamond. Thank you. Dr. Davis, I saw you open your camera. I suspect you have something to contribute.
Sorry, I was a little late today. I had a meeting, but I will say that I have, and I'm sorry, I missed Dr. Diamond's whole presentation, but I have had some elderly, patients of skin of color type 5 and 6 in their 80s and 90s who have had basal cell carcinomas on the face, especially the folks who, grew up before there was air conditioning in their cars and drove around and delivered the mail. And so there are folks who can get it, from sun exposure. It's just delayed by a decade or 2 or 3, 4. So it's just delayed, comes later.
That's great. I see Kyle Kennedy has a question back in the chat again. I'm going to add this to it, and it says, would you recommend biopsy in a primary care setting when we have a question about pigmented basal cell versus melanoma? There's a question about, should we biopsy it now or should we send that into a dermatologist? Again, access can be an issue, but Dr. Diamond, I'll toss that back to you. You addressed this, I think, a little bit earlier, and so did Dr. Buchanan, about biopsy versus watch and how we might get some help with this.
I think it kind of all depends. If you're not gonna be able to get a patient in for 2 or 3 months, or they're not able to drive however far it is to get to a dermatologist, you're better off biopsying it. And I think the reason why people might say that to you is, for a pigmented basal cell carcinoma, you can just take a very thin little shave biopsy without really any depth to it. And it's not going to, it's not really going to make a difference if you don't get to the base of it. Where I think where people may have concern in biopsying a melanoma when you don't do biopsies all the time is that you might not get a representative sample. That being said, if you can't get someone in somewhere for 3 or 4 months and you go ahead and do a biopsy while they're there and you get a diagnosis of at least a melanoma, but they're not sure how deep it is, you're at least going to put some pressure on that patient to get to the right people in a timely manner. The issue is with getting pathologic staging, but that gets figured out when they get treated too. So, I mean, it might not be ideal. They might not be set up initially with the perfect treatment that they're going to end up needing if you don't have a good sample, but I mean, waiting a couple of months isn't the right thing to do either.
Dr. Diamond, I'm going to give you a gold star for answering a question that's very difficult, but putting a very practical application on that. Thank you. I hope that helps our crowd. So,
Thank
And
you.
I might, if I
go
can
ahead,
just
Dr. Davis.
this comment that if as a provider, I'll tell you, if you call a dermatology office and say that you think you have a patient with a dark lesion that could be a melanoma, most of us are going to say, come on in. I mean, I think that's where physician to physician, practitioner to dermatologist communication is so important, because those are one of the things that even our front desk staff they know the word melanoma, and if someone's got that kind of thing, we're gonna get them in.
Yeah,
That-
and just to add to that, these are exactly the kind of lesions that dermoscopy can be helpful with. We can't always make a diagnosis, that it's, 100% a basal cell versus a melanoma. And it can be very challenging to take dermoscopy pictures of nodular lesions. So, the better pictures you can get, it can help our assessment from the consult in, and then we can provide you guys with the most accurate diagnosis, so that then you might, if I say, this is most likely a basal cell, then you might decide you feel comfortable doing a small shave biopsy in your clinic, versus if, this is an advanced nodular melanoma, maybe you have a dermatologist locally nearby that you could perhaps try to get that patient in with. But there's definitely a lot of challenges around it. But I think, having the ability to take these dermoscopy photos and send in a consult, I got a consult this afternoon. It took me 2 minutes and it's already done. As a provider, you have that information really quickly. That way you can kind of then adjust your level of concern and how you communicate to your patient.
Yeah, when I was talking about timing, I think almost any dermatologist, if you call them and you say they're worried about a melanoma, they're going to ask for a picture. If they see the picture and then they're worried about the melanoma, they're going to get them in. I'm talking about getting a patient to go out and actually get there, because I know sometimes in these rural settings they're just not willing to come, on a timely basis. So that's what I was kind of saying. No, dermatologists should see if someone's concerned about a melanoma, they should be getting them in. There's time. There's time.
Dr. Sheldon asks a question which gets to one of the challenges, which is, would most dermatologists see them for a biopsy if they're uninsured? And I don't think we can answer that for every dermatologist, but I think what you've heard from our crew here today is that if you build the clinical case, it's harder for them to say no. And again, the TeleDerm options that we have now, being able to send the images to Dr. Buchanan for some guidance on how best to approach that, I think is extraordinarily helpful. Again, that gets back to Ria's point about one of the things that we hope will emerge from this ongoing educational effort is a greater level of comfort amongst primary care providers who are dealing with some of these challenges by getting the help that a TeleDerm consult can provide. So thanks for that, Dr. Sheldon. Thank you, Mackenzie, also for your comment too about Dr. Diamond's points with skin pigmentation. We're going to start kind of trying to wrap that up now. And I'm going to say that the summary for the case presentations and the didactic session today is, these are challenging. Use the dermatoscopes, use the mole scopes for what they're there for, so that you can get a second. Do we have another case?
No.
Oh, okay. I saw that.
Yeah, Nicole, sir, are your slides back up, or is that coming from here?
Yeah, it's coming from here.
Oh, okay. So we need to go to the end of the slide.
Okay.
Deck. Last couple.
So I'm going to turn it back over to Ria to let her wrap us up so we can get out of here. Thank y'all very much. Ria, it's yours.
Okay, if I can have the last slide, or the second to the last slide. And I will in reference to that question about uninsured patients, we do have a some provision for with lowered rates, or I'm not sure what the word I want is. Dr. Davis, can you help me with this? Arrangements for uninsured patients for treatment here. I don't know if Dr. Davis, you want to address that, but we have a certain.
Yeah, I'm sorry, someone came into my office. Yeah, I mean, we have financial assistance, and
You're-
so people can
you
get
still muted?
counseled.
Dr. Davis?
Can you hear me?
We can. Yes,
Yeah.
ma'am. Go ahead.
We have financial counselors who will help patients who are indigent get into the clinic
Can
if
you
they have
folks hear
something.
what Dr. Davis is saying?
Yes,
I
we can hear her.
We've lost our volume.
we have financial counselors who can help patients who are indigent get into the clinic. And we've also started a free clinic every other month, one evening for patients who are indigent as well through through one of the student organizations. So we have a couple of different ways to get patients who are uninsured seen.
That's great news. I will, since Ria's having a hard time hearing,
We just got back.
okay, you're back. Perfect.
I don't know what happened. So I have to say this was an absolutely great session today. Thank you, Dr. Diamond, for your really great presentation, and Nicole for yours. It's great that we could look at a case that came to one of our clinics, and we had a lot of questions, and we had a lot of new people here. So I do see that we had the family, Phoebe family medicine residents here, and our new clinic Swainsboro represented. So and some other places that I think that we haven't had before. So I'm really thrilled and very happy to have you join us. So our next session will be on December 4th, and that topic will be the red leg by Dr. Lauren Prusinski Furnung. And then we'll have a case presentation by Sarah Atari, one of our fourth year medical students. The CME code is listed here. The number to text to is listed here. It's also been posted in the chat. So at this point, I think that I will wish all of you a happy Thanksgiving. Everyone stay well, and our guests are free to leave now. But our TeleDerm team, please stay on board for a few minutes if you can. So thank you, everyone, and stay well.
Thank you all.
Thank you very much. Very much. It's